Kia ora, Team ICU, and welcome to this PowerPoint show, which is a guide to documentation in the ICU. So this is mainly focused around your 24-hour flowchart and the elements within it, and hopefully you're listening to this and the sound is coming through okay. We normally present this for new starters on the orientation day, but as you can imagine, as with everything in healthcare, our time is limited. And so we wanted to look at ways of giving this information to you that you could just do as and when you wanted to at some point in your orientation. So I'm hoping that you've had a chance to actually have a go at documentation, which will give so much more context to what we're going to talk about. But how this is going to work is we're going to move through the front of the chart and then at the end talk about the assessment that is also important and something we pride ourselves on is a good patient assessment at the start of our shift. So just some things to note. Generally, we do document diligently and thoroughly and systematically, and this is the way that ICU nurses work. If there is a space on a chart that needs something filling in, then please fill it in. And just get used to being diligent documenters. So what I mean by that is, you know, if something happens to your patient, there's an event or there's a deterioration or there's maybe an emergency situation that goes on, then just document it on your flowchart. You're not going to get told off or chastised for over documenting. So the flowchart itself is a document of the patient's progress. It consists of demographic details, family information, medical plan of care, vital signs, targets and physiological targets, fluid balance, and essential nursing cares. And like I say, we pride ourselves on doing all of these accurately and diligently. And we always work on the premise that is, if you didn't write it down, it never happened. So that's just placing how important documentation is in the ICU. So let's move through the flowchart. It would help if you had a flowchart in front of you. And also I'll just add that there is a written guide available for you that you should have got as part of your orientation that you can also use to refer to. Thanks for listening and enjoy. So this is what the front of the chart looks like. This is the business end. This is where you're going to be spending most of your time. And we pride ourselves in the ICU on being diligent documenters. If it's not written down, it didn't happen. And that's basically the premise of all ICU clinicians. So everything that you do, everything that you note, all the care that you give must be documented. No question. But I will just say that the progress notes are also incredibly important. That is also a legally binding document. We really don't want to find ourselves in the coroner's court having to justify our care 10 years down the road. If we haven't written it down, of course, we're not going to remember it. So just to scare you a little bit into being diligent documenters, it's not what we're trying to do, but to just frame one aspect of why it's really important. Now, the other thing I want to make mention of is that when the ward round come to review your patient, they won't be looking at your progress notes, they just won't. So I would get into the habit of writing every little thing down that needs to be documented and that you think the team needs to be aware of on this chart. So for example, if you've had a brief flurry of a tachyarrhythmia and you want to capture that was an episode of SVT, then you can by all means document SVT on your vital signs and make mention of the treatment that you gave or whether it was self-terminating. And again, an example of using the chart to illustrate your patient's progress. So we've split the patient chart into fours, and that's how I'm going to present this presentation. So we've got the left, which is patient details. demographics, next of kin, and the doctor's notes. We've got the vital signs and ventilation obs through the middle. We've got fluid balance and nursing cares on the right, and then on the far right we've got the lines that are in the patients and referrals, and we actually have the interdocumentary assessment on that part of the chart as well, and I'll explain more when we get to that about why we've popped that on the front. Okay, so let's start from the top, or from the left, I should say. Like I've just explained, this is your patient details, the date they came in, their admission date, how long they've been here in days. Their height and their weight is incredibly important. The height we need to be accurate because that's what we put into the ventilator and how we know we're ventilating the patient appropriately. The patient's correct height should be measured on admission, and there are tape measures hanging on each of the ventilators. You might need to go hunting for some of them. Obviously they get borrowed around, but that's why there's a tape measure hanging off your ventilator. Now, weight is incredibly important as well. We use weight to guide our fluid intake. We use weight to guide dialysis. We use weight to guide whether we're going to diuresis someone. And that's why the ward round will always ask, what is the patient's weight today compared to when they were well at home? So the pre-hospital baseline weight, just to clarify, is their weight before they entered hospital. We want to know what their normal, dry, well weight is. If you have a patient that is a chronic kidney disease patient, so someone that's already on intermittent hemodialysis or peritoneal dialysis, this pre-hospital baseline weight is their target dry weight. So this is the weight that they're dialyzed to, and that should be written in those types of patients' notes. We always weigh every patient at 6 a.m. The reason we do it at 6 a.m. is that we usually time it with the very last turn of the shift, the night shift. We take all of the pillows out, we place the patient supine and put a chest x-ray slider sheet under for chest x-ray purposes. And so this is the perfect time. You take everything off the bed, the patient's supine, they don't have pillows weighing down the bed, and we can easily weigh on the fancy new beds that we have. So just to clarify how important that is, again, it will come up at every ward round at 8 o'clock, and the SMOs will need this to guide patients' fluid management. Just moving down, you can see two boxes there in red. The cautions and alerts obviously are, you can see are shaded in red because they're very important. It's an alert. So what we're expecting is that every patient that is admitted, we need to check for any alerts on MAP, and we document what that alert is in the box. If this is a drug allergy, obviously we'll need to pass this on to the medical team, and James, our pharmacist as well. He will come around in the morning, and if you need to talk about a particular drug allergy or you're unsure of whether the drug allergy still stands, please talk to our medical team and the pharmacist. Importantly, we are placing a great deal of importance around safety management, safety of our patients, but mostly safety of our staff. Unfortunately, we do have patients sometimes and relatives with a history of aggression or violence towards healthcare workers, and usually this is an alert that comes up that's attached to the patient. If this comes up before the patient is really known to us, so on their admission, please escalate this to an ACNM, because they will then talk with the security orderlies, who are very, very good at developing plans of care around the what-ifs. We also have an amazing Menaki Whānau leader called Pearl, who is very special to us, and she also is working within this space to help us manage these kinds of situations. So please, there's a lot that we can do, but we need to know about it. So please approach any of the CNSs, any of the medical teams, but especially the ACNMs. Clinical trials, obviously, fairly obvious. It will be fairly obvious what kind of trial your patient is on. In the drawers, there'll be folders related to the research trials that the patient is enrolled in. This can be many, actually. We have over 20 to 30 research trials running in this unit at any one time, and some people have can be enrolled in just one study or multiple. And that's where we just document it there. And all of the instructions for you that you need to know about when you're caring for your patient in these research trials is in those folders, and they're very clear and very easy to follow. Some research trials don't need anything from you. Some might need some specific monitoring or documentation of a vital sign every so often. Next of kin details are incredibly important as well, because we need to be able to get hold of them in case something terrible happens. We need to know where they're staying as well. And one of the things that our social work team are very, very cognizant of is that a lot of our patients do come in from out of town. And you can imagine that this creates not only stress for them, but there's a financial stress as well there in trying to find very expensive accommodation, unfortunately, in Wellington. And at certain times of the year, this is particularly fraught. So please engage the social workers if the patient is from out of town and you think that they're going to struggle either emotionally, needing support, or financially. So the medical side of the 24-hour flowchart, this is where the SMOs will gravitate to when they come and see you on the ward round. They will list the patient issues that the patient has undergone whilst in ICU. Usually 9 times out of 10, patients who have been ventilated, unfortunately, do end up with a ventilator-associated pneumonia. And other issues are documented here, just for example's sake, like fevers and seizures. The plan of care, these are the things that need to be done for the patient today, and then anything that comes up on the other ward rounds, they get documented under additional plans. So we do 3 ward rounds a day. The big one, the most important one, where the patient's plan of care is made, is at 8 o'clock or 8:30. And then they will wander around at 4 o'clock and 9 o'clock as well. And I would say actually the 9 o'clock ward round is incredibly important as well, because this, of course, we're a 24-hour service, and we need to know what care, what treatments and therapies we need to be giving overnight. Things don't just stop because it's night time. Now, the time ready for ICU discharge is something that the ICU SMOs will document. It's one of those reporting elements that's needed for the Australia-New Zealand Intensive Care Society. Don't worry about that. Parameters, obviously, are documented parameters for target vitals that are different from the norm. So normally we keep most patients MAP above 65. But there may be a special subset of patients that may need a higher MAP or a lower MAP, and that's where this is documented. Likewise, for things like intracranial pressure monitoring for our neurosurgical patients, that will also be written down as a target parameter. Now, you'll just see there something called a RAS. This is the Richmond Agitation and Sedation Score, and this is what how we manage our sedation for our mechanically ventilated patients. It's pre-populated on this chart for very good reason, and this is the optimum sedation target for most of our patients. Because this represents something called light sedation, which I'm going to talk about next, but it's really important for our patients. So as I've just talked about, RAS, which is sedation scoring, this is the Richmond Agitation Sedation Score. This is also on the back of your chart in the reference section. It is a measure of how sedated or awake or agitated your patient is whilst they're on sedation. So propofol is usually our sedation of choice. We use propofol because we can stop it and the patients will wake within minutes. We do use other sedatives, benzodiazepine-based sedation we're trying to move away from because it's very, very bad for patients. It creates delirium. In and among other list of bad things that happens to our patients. We do still use midazolam. We use it mainly in our neurotrauma patients when we're trying to keep them very heavily sedated because we're trying to keep their brain pressures down. So they are the group of patients that we would keep heavily sedated for a good 5 to 7 days. However, most of our other patients, about 90% of our other patients, we are trying to keep them lightly sedated. The reason being that we know from research deep, heavy sedation is very, very bad. The list of negative sequelae related to deep sedation with things like an increased mortality, longer length of stay both in ICU and hospital, longer time mechanically ventilated, there's an increased risk of VAP. There's an increased risk of cognitive dysfunction once they've gone home, which can sometimes persist for months and years. It's been linked to delirium. You know, the list goes on and on. So we know from very, very good evidence that keeping patients deeply sedated is bad for them, not only for the time that they're in ICU, but once they go home. So what we try and do is we keep patients sedated to a RAS score of -2 to +1, and this reflects light sedation. So we can let our patients move around. We can let them cough. As long as they're safe and they're not about to lose all of their tubes and they're not rampantly trying to climb out the bed, this sedation strategy is optimum. The other thing I'll just mention about the RAS score is that for all mechanically ventilated and sedated patients, we complete that score in the neuro-op section every 1 to 2 hours whilst patients are being sedated. So just moving down on your flowchart, you'll see there is a tick list, and this relates to the ward round. So these are the things that the SMOs absolutely need to address in all patients. And what these reflect is evidence-based quality of care for ICU patients. So we know, for example, that feeding patients early and optimally leads to better outcomes. We know that taking lots and lots of blood tests from patients all of the time for no good reason is bad for patients because we're taking blood from them. Giving blood transfusions because we've bled them so much from tests used to be the norm 10 years ago, but since the innovation of Choosing Wisely, the international program around trying to reduce nonsense tests and doing things just for the sake of doing, has really driven home the message that we do what we need to do with patients to improve their outcome and nothing more than that. So likewise with the lines that they have in, we recognise obviously that there is a risk of infection with lines and iatrogenesis, and so why wouldn't we be taking them out if we no longer need them? And that's where this gets reviewed daily. Going back to the fluids and daily weight being incredibly important because we tend to give a lot of fluid to our very sick patients in the early days, and we know where that fluid goes and it doesn't sit where it should in the intravascular space. Patients get overloaded. Sometimes we need to dialyse them because they've had so much fluid, their kidneys don't work, etc., etc. Antibiotics, So the obvious reason there is antibiotic resistance is becoming more and more problematic. We need to give the right course of antibiotic just over the right amount of time and not either underdose or overdose. We do a thrice weekly micro round where the microbiology team come around and they review the antibiotic regimes for our patients. Sedation, we've talked about. Analgesia, are they getting enough? Are they getting too much? Are they too asleep? Do we need to get the pain team involved? Family. Usually what this means is, when did the family meeting happen last and with whom and what was discussed? And you can also see on the left hand side of the chart that there is a space to document when a family meeting has been had and who had that meeting with them. Goals of care is something which you should be familiar with if you've come from another hospital or another ward. We do try to be diligent with our goals of care documentation. Every patient in ICU should have a goals of care form in their notes. If they don't, please remind your SMO team. And research. So what this means is there any other research that the patient can be enrolled in, and do we need to think about something else? Now, usually at the end of all of this is when you'll be approached to ask if you need anything, and if you're happy with the plan, please just pipe up. Our SMOs are super, super friendly, and the ICU is a team. We're an ICU FAR now, so please do not be scared to talk about something and don't feel foolish either. Just go for it. And right down at the bottom left there, we've got our IV fluids and enteral nutrition prescription. So this is where we prescribe the fluids and enteral nutrition. It is not on the back of the medication chart like it is on the ward. So this is where you will go to get the doctors to prescribe those things. Now, TPN, it has a separate prescription form, as you've probably known. And just to confuse you, this is where we also put the EVD and a lumbar drain prescription stickers. So if you're not familiar with what an EVD or a lumbar drain is, just talk to your mentor and ask them to show you. Normally we do have neurosurgical patients that have these devices in, and they'd be more than happy to show you what that means. So the middle of the chart is where we spend most of our vital signs observations. You can see top is our neurological stuff with sedation and things like train of 4 and StimPod and dermatomes and motor score. We'll go through that in more depth. Now, in the middle on the left, you can see this is the key to how you document each particular vital sign and using what colour. We are very diligent with this, sometimes to the point of being pedantic, but that's a good thing. It enables us to be able to look at this chart in a split second and perhaps have a look at trends, maybe some progress or deterioration over the preceding X amount of hours. So generally, most ICU patients who are newly admitted and or unstable get hourly OBS. You can do them half hourly. There's space in each of the hours that you can see on that chart to write half hourly OBS. I would say that mostly this relates to our cardiothoracic patients that come to us who can be very, very unstable for the first 12 hours. And this is where you'll see perhaps more frequently than our OBS done. Likewise, we can de-escalate the OBS as patients move through their critical illness and become less acutely unwell and move into a more long-term chronic illness state. And generally we see these with the very, very, very long weaning patients who have spent a reasonably long time in ICU, 7 to 10 days and above. And what we're trying to do there is just not do too much with them. You know, this constant sort of pandering at patients can be harmful. It stops them from sleeping, and we need to be mindful of not doing too much when we don't need to. Now, like I said at the start, we are diligent documenters, and if you don't document it, it didn't happen. You can see there a little snapshot of an example of someone's documentation of an event that they really wanted to capture on the chart. This is absolutely fine to do. And more than welcome to be over documenters. Do be diligent and thorough. You will be praised for it. Your pals will love you for it in the ICU. Any patient agitation, desedation, or dysrhythmia, or an event that has triggered the emergency bell, I would say comes under that component that you can absolutely document that on your chart. But yeah, the major message is just document it. So NeuroObs, very quickly, we have an eye, a verbal, and a motor score, and then an overall score. You guys should be very familiar with doing NeuroObs. Already, the ICU has shot a couple of videos on how to properly do a GCS, because unfortunately there is some variation in people's practice. So what we want to do is obviously set you up for success, and I would highly recommend you watch those videos. All patients, regardless of their admission diagnosis, should have GCS pupil size and reaction documented every 4 hours at minimum. If it's a particular neurological issue that they've come in with, neurosurgical or neurotrauma, they have hourly NeuroObs done, unless the ICU or the neuro team say otherwise. Like I said, with the RAS scores, we do every 2 hours, and CAM ICU, we do every 6 hours. If you're not familiar about what CAM ICU is, we're going to talk about it very shortly, but I'll just leave that there. And I think next up we have the 2 videos of GCS. So again, go into those videos and have a look at them. One of the things that we absolutely must do is that when we're handing over or taking handover from the previous shift is that you will do a neuro observation together. And the reason for this is that not only for the handover of what the patient is doing neurologically, but also if there's anything out of the ordinary that has happened in the night shift and perhaps is evolving over time for your patient, it can also be picked up at this time. So get used to asking your previous shift to do a GCS and a pupil check with you, and likewise you should always do that as part of your handover too. So the other scores and assessments that we do all the time for our patients, pain scores, RAS scores, as I've talked about, and CAM ICU. So pain scores, we use 2 tools. We either use something called the CPOT, which is the Critical Care Pain Observation Tool, or we use the numerical. Now, I don't need to explain what the numerical pain score tool is, but I probably need to explain what CPOT is. So CPOT was developed for critically ill patients, and we're going to talk about that on the next slide. It is a validated measure of pain for ventilated patients and sedated patients in whom we think there might be underlying pain issues. Just to mention that if we are having issues with pain and we just have got multi-agents on board and we just don't seem to be getting there, please approach your friendly SMO team or your ACNM or your CNS, whoever, and maybe talk about activating the acute pain management service. They do round on our patients quite regularly. So let's go through CPOT on the next slide. So the Critical Care Pain Observation Tool, or CPOT. It was first devised and published in 2006 in the American Journal of Critical Care, and you can see there some of the parameters that it uses comes out with a score at the end of it. So the score is out of 8. Facial expression and body movements and muscle tension and compliance with the ventilator. Obviously, if you have an extubated patient who is with it enough to give you a score, then you would use that. But these are for the other patients, those who cannot obey commands or can't talk or are sedated. This is also, I should add, just on the reference chart of your the back of your flow chart as well. So you've always got this this table to refer to, and by and large, the pain scores are very much guided by your patient. You know, somebody that hasn't had a problem with pain, which admittedly is most of our patients who do have a problem with pain, that you could do a pain score every 2 to 4 hours, or hourly if you're having tremendous issues trying to keep your patient comfortable. Could even be half hourly, especially as you're sort of administering analgesics and things. So sedation management, I know I've mentioned a couple of times and I'm going to mention it again. So these are 2 algorithms that are in the red folders by your bedside in the drawers. And this is how we should manage our patients' sedation, how we manage their analgesia and how we manage delirium. This was part of a delirium project that Lindsay developed a few years ago. There's also a delirium pathway, which I'm going to talk about soon. But basically all of this interacts and interrelates. And so you can see there in the middle is how we should manage our sedation according to the RAS target, how we should manage our delirium and CAM ICU delirium assessments, and how we manage our pain using our CPOT assessments. And again, just to reiterate that most patients should not be so heavily sedated that they are generating RAS scores of -4 and -5. This is bad. It's deep sedation, particularly negative outcomes for the patient. So unless it is clinically indicated, you should be aiming for a RAS of -2 to +1. Of course, there are certain patients that should not have light sedation, and those will be fairly obvious to you. It would be those patients with an acute traumatic brain injury, those that have got status epilepticus or seizures that we cannot control by medication alone, fulminant respiratory failure with high oxygen requirements and difficulty ventilating, and definitely patients who are receiving paralyzing or muscle relaxant, because if they're not well sedated underneath that, that could be very, very traumatic for the patient. And trying to fight against something and not being able to move must be terrifying. So that's the group of patients really that we wouldn't lightly sedate. Like I say, they're probably 5% of our patient load. 95% of our patients can be managed with a light sedation strategy. And these are the tools at your bedside that you will use to do that. Some of you guys that have used 4AT delirium screening tool on the wards may not be aware of CAM ICU, but CAM ICU is the preferred validated assessment tool for screening for delirium. It is a bit more complicated than the 4AT, which is just a series of 4 questions. But this is the tool that we use here and in most internationally and national ICUs. We always do a CAM ICU in patients who are non-ventilated and sedated, but actually we should for all patients that are sedated as well. Because if you have a patient who is quite rightly lightly sedated, they should be able to wake and squeeze your hand to command. Of course, there are going to be patients that are lightly sedated who still can't obey commands, and you would have to document those as a UTA, which is unable to be assessed. There are also patients that have significant issues with peripheral weakness and maybe can't squeeze hands to command that's needed by this tool assessment. And how you would get around that is maybe you'd ask them to blink or poke their tongue out or something that you can use to guide what's happening in their head as a response to these questions. There is a video. It is our ICU showing you how to do a proper CAM ICU, and I will also direct you to the delirium guide. The resource guide that's in the seminar room will go through CAM ICU in more depth as well. So trainer 4 and trainer 4 ratio relates to a machine in the ICU that we have called the stim pod. It's how we measure the effectiveness of neuromuscular blockade, so paralyzing agents like atracurium or rocuronium sometimes. We do this 4-hourly for patients that are on those paralyzing agents, because what we want to do is obviously make sure that they are appropriately paralyzed, not too much and not too little, so that they're ventilating, or that we know that we can control their intracranial pressures appropriately. So the aim is to keep 2 out of 4 twitches. So you'll put the probe on the thumb and you'll press the button and it will bleep 4 times and you'll see the thumb flicker. It'll be quite obvious. If you get 2 thumb flickers out of 4, this is documented as a 2 out of 4. This is optimum. You need not do anything with that paralyzing agent, but you would titrate up or down depending on what you get from the trainer 4. Now the trainer 4 ratio is slightly different, but it uses the same machine. So all patients except pediatrics, prior to desedation, we need to do a trainer 4 ratio, and this is given as a percentage. And basically, in simple terms, what this means is all of that paralyzing agent has worn off, and we can be confident when we desedate the patient that they don't have residual blockade present and that they're able to be extubated. So we do it before they're desedated. The reason being, if we're waking them up and they're partially paralyzed, that again is terrifying. We don't want to inflict harm on our patients, and so this is what we do to manage that. So we do a train of 4, which is the twitches, to measure the effectiveness of neuromuscular blockade, and we do a train of 4 ratio to make sure that the neuromuscular blockade is worn off enough for us to desedate and extubate, and the magic number is greater than 90%. There is a video to watch on the actual machine if you guys get a chance. Every patient that has an epidural in gets dermatome levels tested every 2 hours. Ask your mentor to go through it if you never have. We always do a motor score, a minimum of 4-hourly with a patient that has an epidural in. And this is to ensure that the level of block is not too high or too low. But importantly, there's a patient safety aspect to this as well. So if the patient is unsedated, we ask them to lift their legs up off the bed, or we observe what they move during that period of desedation. And it's important that we do that every 4 hours, because we have had patients who have become paralyzed from epidural, either leaching into the epidural space or there being a bleed, and of course we haven't picked up on it because we haven't tested the motor score. So please talk to your mentors about what that means for these patients. So it'll obviously be easy to do that in the patients that come to us unsedated and not ventilated with an epidural. Unfortunately, we do have patients that come to us that are intubated and sedated with an epidural in situ. By and large, what we try and do with those patients is we wake them up very, very, very early, and we either observe them moving their legs, or we wake them up and we ask them to move their legs. If the patient can be extubated, of course we extubate them, and if they can't be, we resedate them, but we keep waking them up every 4 hours to test that motor score. So just in a bit more detail, vital signs explained. I already said that we do them at least hourly, but they could be more and less frequently as required, depending on your patient. Temperature is taken a minimum of 4 hourly unless the patient has a temperature probe in situ, and usually this is in the nose. Then it's recorded hourly. It's actually on the monitor. We have a cable that attaches to a temperature nasal probe. If there are periods of patient instability or a change in status, document this on the flowchart. If you need to do half-hourly observations, do that. If you've had multiple interventions to assess, to address deterioration, document these also. These could just be bullet points. because all of this information is really invaluable in helping the medical staff when they're assessing the patient on the ward round, and it helps them develop their plan of care. All cardiothoracic patients have a CVP, a central venous pressure monitoring recorded every 4 hours or after giving fluid. And then once the patient is off vasopressors and is extubated, we usually discontinue CVP monitoring. We only do CVP monitoring now in our cardiothoracic patients. Active cooling and warming is performed regularly in the ICU. We currently use the Striker machine, but we've got something else called the Polar Air. Strikers are by far the better machine. It's basically a machine-driven water cooler that circulates through a blanket placed underneath and over the patient. For rewarming, we use something called the Warm Touch or the Bear Hugger. It's imperative that you monitor the patient's core temperature, either using an IDC or a nasopharyngeal temp probe, like I've just explained. But for patients who are not being actively cooled, and most of our patients, an auxiliary thermometer is fine. So when we're documenting and monitoring, we write the actual number, which is the mean arterial pressure. So even though we do obviously take into consideration and do document systolic and diastolic blood pressures, we usually use MAP to target therapy. So that's a really important number. Obviously, we need to know what the cardiac rhythm is. You'll see that most of our patients do at some point have a little flurry with AF. This is relatively normal for our patients, but still needs treating and managing. Our aim is either to revert the patient to sinus rhythm with drugs, or mostly drugs actually, sometimes cardioversion. But if we know, for example, that the patient normally has pre-existing atrial fibrillation, what we'll try and do is, obviously there's no point trying to actually cure that if that's long-standing or chronic, but we'll try and get it down to a rate that means that they're not tachycardic, because that just puts extra work on the heart. CPP and the cardiac index. So CPP is cerebral perfusion pressure, and this is derived from the patient's MAP and minus the intracranial pressure. So it's obviously related to our neurosurgical patients. CCI is the cardiac index. It's a continuous cardiac index. That's what actually the acronym means. And this is taken from something called a pulmonary artery catheter. You won't see these during your orientation unless you have come from another ICU. These are very, very, very sick cardiac patients. The SVO2 measurement there is a measure of venous oxygenation. It's also a sort of surrogate measure of perfusion, and that as well comes from the pulmonary artery catheter in these very sick cardiac patients. IABP is an intra-arterial balloon pump, and that's a balloon pump that sits in the aorta. Again, not something that you're going to see during your orientation unless you've come from another ICU or you've got CCU experience. Blood glucose should always be monitored 2 hourly if the patient's on a continuous infusion. However, because there are several regimes that we use interchangeably, especially if patients are going to the ward, please just refer to what regime the patient is on and follow what it says on there in terms of monitoring blood glucose. All drug infusions and their concentrations are recorded in this section. Record the hourly dose of the drug. So the patient's weight is required for this calculation, and you can get this printout from the database for certain drugs, which I'm going to talk about the ICU database later, but these are the drugs that you would be able to get a corresponding mils per hour as to the mics per kilo per minute that you need to document on your flowchart, and it's these drugs that relates to. Just a note here that all drug infusions and syringes and prepared medications that are by your bed should be checked against the prescription and handed over shift to shift. You can see Caitlin and Ayla here diligently going through Ayla's medication chart, and they're doing a handover of the drugs that Ayla has already prepared. The reason for this is obviously medication errors happen commonly in the intensive care unit, and thankfully, these are pretty low rent medication errors, but still, we need to be aware that actually we're giving a lot of medication in a 12-hour shift, and we need to be diligently handing all that over. So on your orientation day, you will have gone through the ICU database and around the, in particular, nursing discharge. This just shows you where you get those drug calculation breakdowns from. So you go into reports and forms, then you go into drug calcs, and there you go, hey ho, it's all there ready for you. So respiratory and vent obs, I don't want to go into this too much because you're going to get experience with your patients during your orientation, but this is a whole lot of parameters that we document from the ventilator. Obviously we're also documenting the SpO2, but the other thing that we're also documenting is the end tidal CO2. So all ventilated patients have an end tidal CO2 monitor on if they have an oral endotracheal or a tracheostomy tube. It's the numerical value that's documented hourly. However, it is the waveform presence that confirms airway patency and placement, and this should always be observed. If something happens to your trace, you need to address it right then and there, because what we're obviously quite concerned about is airway obstruction, and if you lose that trace and there is airway obstruction, this is a medical emergency. So talk to your mentors at the bedside about some of the things that you know might alter your trace, some of the troubleshooting that you need to do with your patients, and obviously what to do in an emergency situation, which is always drop what you're doing. Make sure that the patient has got a patent airway. So you go to the patient, you do a very, very rapid respiratory assessment, check the airway, check the tube, check that the patient's, for example, not got a heap of secretions down there, and that's the reason why they've obstructed, and you press your emergency bell. Fluid balance is complicated. I'm not going to lie to you. It's going to take practice, and it's going to take sitting down with your mentor how to do it correctly, because it is quite nuanced. Generally speaking, fluid that's infusing on a continuous basis is fine to write the mils per hour in each hour. So you can see there that DEX 5%, which is our maintenance, and nasogastric enteral nutrition, which is our ppmf, is generally going at the same rate the whole time. So that is fine to put there, that if it's going at 30 or 20, just put that that's what's going in each hour. Now, syringe driver levels need to be measured hourly and written in black and blue, black or blue, I should say. The following hour's level is subtracted from the previous hour's level, and that will be what's written in red as the amount that's gone in per hour. All infusion pumps write down the volume to be infused and subtract that from the previous hour's volume to be infused, and that gives you your hourly total. All IV additions, all flushes, no matter how small, they're also documented on here. So if you've given a 10 ml of antibiotic and you've followed it by a 20 ml flush, you would put 30 ml in for the IV adds. Each time a new syringe is put up, it should be documented on the fluid balance chart as the volume in the syringe, and then that's circled, as you can see there, for the propofol in 90 ml gone in, programmed into the pump. So there might be 100 ml in that bottle, but we know that we need a little bit of time to get the next bottle ready, and we need a warning. So we put 90 ml in, and then the alarm will go off when 90 ml has been given. And then while you're preparing your next bottle, you've got a spare 10 ml to play around with. So each time we put a new bag up as well, I should just add that the amount that we program into that pump for patient safety reasons, especially with things like sedation and especially things like inotropes, we need to be fairly sure that when that bag empties or when that bag alarms, that we've got plenty of time in which to put another bag up. So by and large, what we say is that for anything that's 100 mils that we're putting up, we program that in as 80 mils. Now, if you're priming the line, you might need to give a little bit more leeway because you will have used some of that 100 mil volume to prime that line. 70 mils, 70 to 80 mils usually is sufficient to give you prior warning, and you will become very, very practiced in having everything ready just at the right time. So, you know, don't worry too much about this, but as a general rule, 80 is the magic number. Okay, so moving on to drains and outputs. Again, the complicated thing with this is the drains. So typically what this signifies here is a cardiothoracic patient who's got a couple of drains in. So there are some patients that can have more than 2, 3, 4 drains. If you need to, you can chop up another 24-hour flow chart and stick it over the top so that you have got more space to put more drains in. We document urine and bowels. So bowels open for the shift gets documented there at the appropriate time. And we also tot up the total drained, the hourly output, the total output, so that's the running total output, and then the total fluid balance. Now, what becomes incredibly important at midnight is that midnight is the time when we do our 24-hour total in, total out, and balance. And we also look at our cumulative balance. So we do a total in and a total out of all the ICU flow charts, all the ICU days for that patient. And what we end up with is a complete cumulative balance for the patient's entire stay. And it's that number that becomes incredibly important for the ward round to guide dialysis. It can mean the difference between your patient going onto dialysis or coming off, or, you know, giving furosemide or other diuretics. So be very, very diligent with fluid balance documentation at midnight, please. Again, importance of midnight fluid balance calculations. We also calculate every line and every column of total in, total out, 24-hour balance and cumulative balance. Again, incredibly important. Now, the reason that we do the every line and every column is because it picks up calculation errors, and unfortunately, you know, tired, busy nurses do make mistakes. Sometimes there can be litres of fluid out of the fluid balance, and this is just another way of making sure that what's documented is true. Nursing care is documented here. We do minimum turns and repositions, minimal 3 hourly. We also have our patients sat up at 30 degrees, and that's most of our patients. Best ICU mobility scale, don't worry too much about this. This is for our physio friends to document. Mouth and eye care we do every 2 hours, and our mouth care is using filtered water and mouth swabs, but also we are very, very diligent in brushing our patients' teeth, a minimum of 6 hourly. And the reason for that is that we know that brushing patients' teeth, 1, it stops dental caries, and 2, it actually prevents ventilator-associated pneumonia. So mouth care, incredibly important in critically ill patients. We change comfort tapes every shift. If they have an anchor fast on, that's every 5 days changed. We always change the tapes around the NG tube of 12 hourly because sometimes the tube abuts the nasal cavity, causing pressure injury, and we need to know about it and re-anchor it away. And this is also where we record our neurovascular OBS, so pulse, colour, warmth and movement. So moving on to the right-hand side of the flowchart, you can see the apparatus box. This is pretty self-explanatory, but any line, drain, tube, that is in the patient gets documented on this chart, and you can see that we're asking for where the position or the site of the tube is, the date it was inserted, the ICU day number, and of course when the dressing was last changed. There are a few other things on this part of the chart which I'll go through in the next few slides, but just suffice to say that with any indwelling IV device, we take infection control really seriously. We use the aseptic no-touch technique to manage our indwelling devices. And of course, you may have heard about the scrub the hub and let it dry protocol, which is what we follow in the ICU. And generally what we say is every time you are accessing the line or the device, you scrub the hub for 15 seconds and then you have to let it dry for 20. Now, there are some differing opinions on how long both of those aspects should be. Some say 10 seconds and 10 seconds. And we've just opted for a general guide of 15 and 20 because that seems to fit with what other units in the country are doing. But generally, we're using this to guide our practice with all our IV devices. Indwelling IV device CLAB, so central line, especially associated bacteremias, are very common in ICU patients, and they can really set the patient back and be pretty devastating sources of sepsis. So this is obviously very, very essential management and care of our patients, given how many of them and how many devices patients have. So as part of our IV management and good infection control practices, we also change the bungs on all peripheral IVCs, PICC lines and CVL devices. You can see there at the bottom right, that's the bung that we use. We make sure they are changed every 96 hours or every 4 days. The other thing that we do is we change them before we take blood cultures. And the reason we do that is we want to have as clean a catch, cleaner sample of blood as we can. Obviously, if the patient has had their line accessed multiple times for blood tests or things like that, then blood sits in that bung and you've got a hub of microorganisms sat in there. So we need a cleaner catch as possible from the patient's blood to enable correct identification of microorganisms and the right antibiotics. Once a bung has been changed, please document in the apparatus box. You can see there that there is a special box for CVL bung changes because there are different lines, either a triple lumen or a quad lumen, and we want to kind of make it clear which one we've actually changed. So each time we change a bung, we write the date that the bung was changed on whatever line it is, and we keep transcribing that until the device is either removed or we change the bung again. So we should keep transcribing it with the date that it was last changed until the next time it's changed again. Patency checks of your lines are also documented on this chart. You can just go ahead and tick when you have accessed the lines that you're not using. And really what we do is ask at the start of each shift, you're going to aspirate each of your lines that you have free, and you're going to flush them with a turbulent flush, and then you're going to clamp them. And there are two reasons for this. First of all, it gives you confidence that if you need to give something in a hurry through that line, you know that that line works. But also it just keeps the flow through that line, keeps it patent, and also reduces the chance of infection with the turbulent flush. So please document this every time you access and you check the patency, or you aspirate and flush each of the lines that you don't have any infusions running through. Phlebitis scoring we also do once a shift. and well, it's clear why we do that with those images on the left. They're pretty horrific. Please document phlebitis scores on all of your intravascular devices and record on the apparatus section. So you can see also on the apparatus section that there is a couple of lines with stitches and staples on there. So the aim of that is actually to ensure that there's a trigger date for us to remember to remove stitches and staples. We've had a few incidences where people have forgotten that actually the patient has stitches in situ, and typically these have come from patients that have had previous chest drains in, but we've actually forgotten that a stitch needs to be removed 7 to 10 days afterwards. In your red folders, there is a guide to the commonly placed surgical staples, stitches that our patients usually present with, and when they should be taken out. And in the documentation resource book that you would have received as part of your orientation, if you haven't, by the way, you need to go back to the educators and ask for one. There will be a section on how to complete the stitches and staples part of the documentation, because really it depends on what you're taking out and where from as to how you document the trigger date for removal of the stitch and the staple. So just follow that really simple guide, and the actual stitches and staple guide to removal timeframes is actually in the red folder. And just moving down the right hand side of that chart, write down any tests and investigations that you have done. So that's anything that you've, either an ECG, or if they've had a CT scan or an MRI, or they've had a blood test, anything, chest x-ray, you name it, goes here. Trend care. Predictions we complete by 9 AM and we actualize the patient at 2, 10 and 6. This must be done. We also use patient diaries in this ICU as a way of bringing memories back for our patients. And if you have a patient that's been in the ICU for greater than 8 days, please either talk with your ACNM or your next door neighbour, or please the CNSs, and talk about whether you think a diary could be started. Any referrals that you've made today also gets ticked on this part of the chart. Skin assessment is massively important in our ICU patients. We have a huge problem with especially incontinence associated dermatitis. We see a huge amount of patients that have skin loss and pressure injuries for good reason. These patients represent the sickest patients in the hospital. They're immobile. They come to us with comorbidities, and we give them medications that are not good for patients' skin, lots of different reasons. And so that's why we have this skin bundle. So please take a look at this. This is in your red folders. This basically documents how we should manage every single patient that comes into our ICU and their skin. So we do a skin check under all of their devices in the day and the night, so once a shift. We also check all pressure areas, all bony prominences, sacrum, heels, occiput and elbows in the day and the night. And if you find an injury that's either an incontinence, dermatitis, or a pressure injury, or a device-related pressure injury, we're particularly noting device-related injuries are so common in our patients' endotracheal tapes, so the comfort tapes in particular, but also the tracheostomy tapes around the back of the neck and the head is often where they'll sustain these pressure injuries. And if you're not checking diligently, it can go unnoticed for days. We have had a patient that needed skin grafts on the back of their head and the nape of their neck from the ties cutting into the back of their neck, and that was pretty embarrassing. Please do a square, do a pressure injury sticker and place it in the patient's notes, and start a wound care chart. If you've done a square, you can document the RE number here. Incontinence associated dermatitis from diarrhea is probably the biggest problem that we see in our patients. And so we have something to guide our care around that. And the magic therapy that we can do to prevent this is by using Cavalon Advanced. We do keep it as stock here. We use it a lot. You can either use Cavalon Advanced daily or every other day or every 3 days. And depending on the level of diarrhea or how bad the patient's skin is will dictate whether they get dosing of Cavalon Advanced daily, every other day or every 3 days. This is in your red folders as well. Please look at this. We will start prescribing Cavalon Advanced according to this algorithm, this pathway, so that actually each day we give Cavalon Advanced according to the patient's diarrhea on that day and according to their skin, so that we can flex up or flex down the dose of that Cavalon Advanced. The other thing that we can use in our patients, which we have only really just started using much more, is loperamide. And, you know, for those really problematic patients with diarrhea, the hem-onc patients in particular have horrendous problems with toxic diarrhea. And so we need to get on top of this early. We need to use this algorithm with all of those patients. And all of our ICU patients with potential skin issues and diarrhea. So near the bottom of the right-hand side of the chart, you'll see these two things, the nursing plan of care and nursing notes and handover reminders. And that's exactly what they are. These are your spaces to do with whatever you want. If you're a list person and that's how you remember to do important things at certain times, then please go ahead and use these boxes. It's very much your space to do with what you want. You'll see down at the bottom there as well, there is a controlled drug handover checklist. This is for you to please hand over at shift changeover any opiates or sedation or any controlled drugs that you have got drawn up into PRN syringes and you're giving via bolus. This does need to be documented here. It is a legal requirement. You will also, of course, be handing over your drug chart as well and checking those against the drug chart and the prescription. At the bottom, space for you to write your name and what shift you were on. Okay, moving on to the back of the chart. So this is your start of shift assessment and your quick reference. So just very, very briefly, this is where you'll find your CPOT, your GCS, your RAS, and dermatome assessment scales. So every single patient that you take over or you're caring for has an assessment and a safety check done. It does not matter who that patient is or why they're in, they get the same assessment and safety checks. And obviously, you know, the reason is pretty obvious. It's to maintain safety and make sure you have the right equipment for your patient, make sure all of the elements that keep them safe in that bed are done. So be systematic and thorough. All things that are in red are the most important. If you have a busy patient, do those first. So at least you start your shift knowing that you've got everything in place for safety. The skin assessment, like I've said, is on the front of the chart, and it's there so that if you don't get a chance to do it at this time, then you can do it at your next turn. So that might not coincide with your patient assessment. So that's why it's on the front. So at the start of your assessment, we use the A, B, C, D, E approach. So airway, obviously, and breathing is A and B. Move through each of the elements of the assessment in a systematic way. If there's a place to document something, please document it. If you're not sure, try and find the answer. If you're not sure, for example, when vent tubing was changed, but you know that the patient's been in for, 4, 5, 6, 7, 8 days, then just go ahead and change it. And make sure that it's labelled so that the next person can know when the vent tubing's been changed. Likewise with anchor fast. And this is also where you would do a lung auscultation. Have a listen to your patient's chest. All patients have a cardiovascular assessment. However, only cardiothoracic or cardiology patients, for example, those with pacing and pulmonary artery catheters, require the part of the assessment that's covered by those. So if your patient is not, then just put a line through it and move on. Make it simple and easy on yourself. Chest drains, that's not just cardiothoracic chest drains, but any chest drain for any patient can be documented here and assessed. Likewise, all patients have a neurological and GCS assessment performed. But again, if your patient's not neurotrauma or trauma or neurological or neurosurgical patient with an EVD or an ICP or a lumbar drain, put a line through that and move on. Gastrointestinal and bowel assessment is important. Obviously, you know, a lot of our patients are at risk of ischemic bowel, and so it's really important that we do a thorough abdominal inspection and palpation and auscultation, but obviously bowels are incredibly important as well. We do have problems more so with diarrhea than constipation, and we have a constipation guideline that Kathy has developed that is also in the red folder, so please use that each day, and just go through the elements that relate to your patient. Document your Braden score every shift. And any surgical wounds or pressure injuries, you can document those here. If your patient has come to us and they're out in the community and they're a renal patient, so if they have a fistula or a Tenkoff or a tunneled line, please let the ACNM or the CNS know, because we need to tell the renal CNS nurse, because they come and help us with these patients and make sure that these devices are kept clean. It's written in our policy that we do a moving and handling assessment at the start of every shift. You can do this so rapid. Essentially, you just circle all the criteria that applies to your patient, and you always make sure you have enough people to help you when you're moving and handling. It is a minimum of 3 nurses to turn a ventilated tubed patient, and that includes patients with tracheostomies. Infection control and isolation obviously is big business at the moment with our RSV and COVID and etc. We need to know what kind of isolation they're in and make sure the sign is visible and present on the door. Staff safety is incredibly important to ICU and the organisation, and we are committed to ensuring staff safety, and this is why this is flagged as red. You need to look at MAP and see if there is any patient, staff or safety family concern, and if there is, you need to talk to the ACNM, and we keep the stickers by the ACNM computer in the central area. So if you have something that's flagged or something is handed over to you, or you witness something from your relative or your patient, please approach the CNS team or the ACNMs. So these safety checks are in red. These are the highest of priorities. Please do each of these in every single patient that you have. They supersede the rest of the patient assessment and should be done within the first half an hour of your shift. This is the red folder that I've been talking about throughout this presentation. This is in your drawers, and it has the resources that you need to care for your patients, and these are the things that are inside them, but I'll just let you go away and have a look at them yourself when you have time. Handover and progress notes, incredibly important. We know that critical information is lost between service to service. We also know that critical information is lost from shift to shift. If you didn't write it down, it didn't happen. We've already said that. So please be thorough and concise in your writing, especially address all of your patient systems. The progress notes should be a reflection of the whole 12-hour shift, not just the snapshot at the time of writing. So the flowchart complements the progress notes and vice versa. Everything that's on the flowchart can be alluded to in the notes, but don't just transcribe numbers and vital signs. That's of no use to anybody. It's already written down. Don't make work for yourself. Tell the story of your patient in that 12 hours. The flowchart is the reflection of the dynamic changes in your patient over time. But the progress notes are more of a summary of what the patient has, what we plan to do with the patient, what the patient did, and what happened over that shift. And you can use the ABCDE format. And please, likewise, I know that this on the left is a handover guide, but you can also use that to guide how you write notes. So they're interchangeable. So at the handover, please use this guide to help you be systematic and thorough. And when you get particularly practiced at this, you'll just know. It will just flow, and you'll use your flow chart. But this is there for people to just be a bit more systematic and to bring all of the handovers and the progress note writing in line with the unit expectations and the policy. We have a handover tool. That's for when patients come through the door by another service or another specialty, or from the ward or from the PAR team or from the flight team. This is the tool that is used to guide that process. We use ISBAR to form the communication around our patient, especially around deterioration, and how we hand that over to the medical staff. You should be aware of ISBAR as it's a national program. And the PADP we don't use too much in ICU, but we do expect that people fill in the front sheet and then turn the page over, and the valuables is the most important thing. This is the only place that we have to document the patient's valuables that come in, so please do this with all of your patient admissions. And just finally, families are incredibly important to us in the ICU. They are an extension of the patient. We take care of them as well. And the way that we take care of them is we communicate well, and we give them information, and we make them feel welcome. So please, whenever you have a family member that comes to see their loved one, you give them the visitor information pamphlet. Likewise, we've got a special pamphlet around delirium. Delirium can be incredibly distressing to relatives, and they just need to understand what it is and how common it is. Delirium pamphlets are in the same place as the visitor information pamphlets, and you'll, if you don't know where they are, they will probably be shown to you on your orientation, but just ask any of the nurses or the ACNMs or the CNSs, and they'll definitely point you in the right direction. So that pretty much concludes the documentation module presentation for you guys. I know it's taken a wee while because it is a rather hefty beast, but please keep practicing, keep asking your mentors to help guide you with your documentation, and thank you for listening. Thank you for your time.